مساء الخير على حضراتكم. يعني الحقيقة الحضور لسه جميل والسيشنز مكملة. هنروح شوية بعد السيشنز الجميلة اللي سمعناها لل Pediatric Endocrinology. قبل ما أقدم our speaker عايزة أشكر أختي وحبيبة قلبي أستاذة الدكتورة شيرين شلبي. أنا بصراحة بموت في المؤتمر ده وبحب أجي أحضره بأي شكل من الأشكال. أنا ثابتة على طول، يسعدني ويشرفني، وسعيدة بوجودي مع الشير بيرسونز، يعني يشرفني وجودي معاهم. وهنبدأ الجلسة. يعني it's my great pleasure to introduce our international speaker, Professor Abdelhadi Habeb. Professor Abdelhadi is a key opinion leader in the field of pediatric endocrinology in the Middle East. He is a consultant pediatric endocrinologist in National Guard Hospital, Medina, KSA. He is the chair of therapeutics committee in the same hospital. He is the ASPED Secretary General, and ASPED stands for Arab Society for Pediatric Endocrinology and Diabetes. He is the coordinator of ASPED SP Endocrine Academy and a clinical examiner in the Royal College of Pediatrics and Childhood. He has more than 60 publications in the field of pediatric endocrinology and diabetes, and most important, he's a very dear friend and colleague whom I enjoy working with for a long time, since 2012. الحقيقة لو هتكلم عن عبد الهادي أنا ممكن أقعد بقية السيشن أتكلم أكتر كمان. يا تكسبي يا شيري، يبقى أنت تكسبي. يعني it's my great pleasure to welcome Professor Abdelhadi, and he's going to give us some tips and tricks in pediatric endocrinology. Abdelhadi, please start.
Assalamu alaikum jami'an. Thank you very much, Rasha, for the introduction. And I would like also to thank Professor Shireen Shalabi, whom I know for more than 15 years. And I think when Shireen asked me to give a talk in the conference, I said, who are your audience? And she said, they are mainly general pediatricians. Some of them are in training, some of them are finished trained. So it was really difficult to pick and choose what to talk about from the endocrine curriculum. So I thought the best way forward is to select a few cases from which lessons being learned. Yeah, and these are patients whom I managed, or at least I was the principal consultant in their management. Some of them were managed nicely, some of them mistakes were done. So, but we learn. We always learn from our mistakes. I say. I mean, the first tip I would like you to know is pediatrician, they can collaborate together, and this is an example of a paper we published 12, 13 years ago, and you can see it was co-authored by endocrinologists and nephrologists. And you can see the name of Dr. Shireen Shalabi over there. And beside the fact that this paper showed a high incidence of type 1 diabetes in Medina, it really showed for the first time that the rate we have is among the 10 highest rates throughout the world. We're not going to talk about incidence of diabetes, but I'll take about this 10-year-old girl who presented to us a long time ago with abdominal pain and vomiting. She went to the first hospital. It was a private hospital in Medina, and over there they confirmed that she has tender abdomen, was given analgesia, seen by a gastroenterologist who felt that she needs endoscopy, but the parents said no. So she went up to another hospital. 2 days later, the girl continued to have pain and she became unwell. In that hospital, they were clever enough to measure her blood glucose, and as you can see, it was 430, which is high. She was also acidotic and therefore they transferred her to us in the maternity and children hospital in Medina. And when she came to the emergency department, she was in shock state. She continued to have abdominal tenderness, and her blood glucose was as high as in the previous hospital. She was acidotic, and her urine analysis showed 3 pluses of glucose and 2 plus of ketones. So the working diagnosis at that time was newly diagnosed diabetes in diabetic ketoacidosis. And I'm sure the majority of you will probably agree with this, but wait until we hear the rest of the story. So she was admitted to the PICU, given the usual management of diabetic ketoacidosis, fluid, insulin infusion, and monitoring. And within 8 hours, everything improved in terms of number, pH normalized, glucose normalized as well, but she continued to have abdominal pain, and she started to have more vomiting, gardening, rigidity, and at that time there was no ketonuria. And the question was raised whether this was really a DKA or something else. And when you have a gardening or rigid abdomen, you would like to see the opinion of the surgeon. And we know the surgeons are very interactive people, and they are very proactive. So they took her to theater, and that's what they found. They found a twisted bowel. It was a bit too late because it was mostly gangrenous bowel. And the operation went fine. The scar was okay, but the girl lost the majority of her bowel. And the diagnosis was really stress hyperglycemia due to mid-gut volvulus. So it wasn't really diabetes. We blame surgeons, and I heard this morning one of the speakers saying we missed abdominal pain and turned out to be diabetic ketoacidosis. Yes, that's true. But sometimes we overdiagnose or misdiagnose things, and we rely on the surgeon to correct us. So we all know why patients with stress in general, infection, whatever it is, can develop hyperglycemia, and there are different mechanisms. I'm not really going to waste your time on this, particularly at 5 o'clock in the afternoon, but just remember, whatever it is, you can have a combination of 2 things. You can have increased gluconeogenesis as well as insulin resistance, and this leads to hyperglycemia, ketonuria, and acidosis, mimicking diabetic ketoacidosis. And I think the lesson we learned from this girl is that hyperglycemia and acidosis is not always diabetes. The other thing is most children with newly diagnosed diabetes, they really should have other symptoms apart from the abdominal pain and the high blood glucose and ketonuria. They usually have polyuria, polydipsia, weight loss, and this girl didn't really have this. DKA can present with abdominal pain, as I earlier said, but it's usually associated with severe ketonuria, and if it's really diabetic ketoacidosis, they don't improve within 8 hours. Again, as I said, persistent abdominal pain after correcting the acidosis, and the child continued to have, and the hyperglycemia, you really need to ask your question or yourself the question whether this is what we are dealing with or not. So don't be afraid. You can always ask your surgical colleague to have an eye if you are not sure about the diagnosis. Now, let me move to another scenario, and this is a 4-week-old boy of consanguineous parents, and this is very common in Medina. He was the first baby born at term, but he developed vomiting and poor feeding and came to us at the age of 2 weeks with a picture of severe dehydration. And you can see here his genitalia. He's got very respectable penile length, has got rugged scrotum as well. His glucose was a bit on the low side, sodium very low, potassium is very high, acidotic, high urea, indicating he was dehydrated, and also his creatinine was on the higher side. And the diagnosis is congenital adrenal hyperplasia. Thank you very much. So he was managed nicely using the IV fluid, hydrocortisone, and everything. And we ask ourselves how we confirm this diagnosis. Of course, we'll say, well, we checked 17-hydroxyprogesterone, ACTH, but these things can take some time, particularly if you don't have really the facility to conduct these tests in your hospital. Now, the ultrasound is very useful. It can really help you in such scenario. And indeed, in this child, the initial ultrasound showed that he has more of juicy adrenal, indicating that he might have congenital adrenal hyperplasia. A few days later, everything normalized, improved, and the 17-hydroxyprogesterone came back confirming what you all suggested as a diagnosis. And a few months later, the nice thing about endocrine is if you treat your patients properly, you can see how the child improved over the period of time, just on hydrocortisone, fludrocortisone, and sodium chloride supplement. But he still has a very respectable benign length, and I think this will take a long time. Life is not always like this. It's not very easy. This is another scenario. Similar story, slightly different version. 3 weeks old, consanguineous parent, first baby, born term, few days of fever and vomiting, 5% dehydration. Unfortunately, I don't have a photo of this child. And he's got a similar electrolyte disturbance, sodium low, potassium high, creatinine a bit higher. If you remember, the previous one was 60, this one 101. He has normal male genitalia, and there was no history of neonatal death or ambiguous genitalia. And this is the sort of things which we talked about. We'll do ultrasound, 17-hydroxyprogesterone, and probably we can measure the aldosterone and plasma renin activity if available. But the thing I would like you to remember is the ultrasound is the sort of things which can give you immediate answer. And it takes, in good hands, it can give you a lot of diagnosis. So what do you think about this picture? Is it another CAH? We'll find out. This is what the ultrasound showed. It showed dilated ureter and kidney, pelvis. So this child has got what? Hydroureter. Yeah? And he was given intravenous fluid, antibiotic because he has fever. Culture was taken, and we referred him to the nephrologist because we felt this is more of a kidney problem rather than congenital adrenal hyperplasia. And the hint is the genitalia were normal, and the ultrasound showed obstructive uropathy, or a picture of obstructive uropathy. A few days later, everything normalized, and the culture, in fact, grew E. coli, confirming that this child has a urinary tract infection on the background of obstructive uropathy, and that's why he developed this picture. His aldosterone was very high, indicating that there was a state of aldosterone resistance. And indeed, when the MCUG was done, confirmed that this child has got a posterior ureteral valve causing the obstructive uropathy with the UTI leading to aldosterone resistance, which is usually transient. And this is a very nice review or systematic review article published this year, raising the awareness about this condition. As you can see here, the majority of these patients who have secondary or transit pseudo-hypoaldosteronism due to the UTI and the obstructive uropathy or the renogenital anomaly, they usually have problems. This picture in the first few months of life, it's mostly are poised. Out of the 124 cases were reviewed in this article, 25% of them were misdiagnosed as having adrenal insufficiency or maybe adrenal crisis. They come with the same picture, but you have to think, if you don't really find anything on clinical ground, to rely maybe on the imaging because it is something available everywhere. And in good hand, I think at least can make you the diagnosis of this one. Out of these patients who were reported, 80% have congenital anomalies of the kidney and urinary tract. The exact mechanism is not clear. The good news is if you treat them with antibiotic and IV fluid, the picture improves within a space of a maximum of 10 days. That depends on the associated pathology. So low sodium, high potassium in an infant with vomiting and dehydration, yes, it can be a typical of adrenal crisis, congenital adrenal hyperplasia, but it's not always like this. I'd like you to think about two things. Maybe the child have a transit obstructive or transit pseudohypoaldosteronism due to obstructive uropathy or UTI, or the child may have hereditary form of pseudohypoaldosteronism, which is a permanent thing. Ultrasound is very useful. And look for the creatinine. Usually, babies with obstructive uropathy will have a higher creatinine, as you've seen in this child, compared to the congenital adrenal hyperplasia. Right, we'll go back to diabetes. This is a girl who was referred to our combined endocrine hematology clinic in Medina a long time ago. She was born at term, normal birth weight, and she developed anemia at the age of 4 weeks. Her hemoglobin was 6.2 and the platelet was low. She had blood transfusion, and then 2 weeks later she developed diabetes, continued to have transfusion in the first year of life, up to 9 transfusion. She had 3 bone marrow biopsies in a different hospital. None of them really reached the diagnosis. So the patient, the family said, okay, because they live in Yamba, and I'm sure Dr. Shireen knows how far Yamba from Medina is. Very nice resort if you are visiting Medina. The parents said, okay, let us move to Medina instead of reviewing the hematologist and endocrinologist in Jeddah. And she came to our combined clinic. At that time, she was on a high dose of insulin. Her A1C was high, continued to have a low hemoglobin. The MCV was normal and the platelet was also on the lower side. We thought about a condition called thiamine-responsive megaloblastic anemia, but the MCV was not megaloblastic. But my hematologist colleague told me, because she had loss of transfusion, you can't really rely on the MCV. So we did a hearing test, and that confirmed that she has bilateral sensory neural deafness. Genetic testing confirmed that indeed she has this condition due to mutation in the SLC19A2, and I will tell you a bit about it. So in addition to the insulin, we started her on thiamine, and we also requested for her to have a hearing aids, and this is her hemoglobin A1C. If you can see, it dropped very nicely within a space of 18 months to near normal. With that, the insulin dose was also reduced, and she needed no further blood transfusion until today, and she's 12 years of age now. She's still needing hearing aids. She has a little bit of learning difficulties, but at least she had no need for further blood transfusion. And this is a rare condition, I'd say, and as the name suggests, it has anemia, deafness, and diabetes, beside other features such as thrombocytopenia, short stature, cardiac, visual, and neurological defects. It's caused by mutation in the gene encoding the thiamine transporter protein. So these patients, they don't have thiamine deficiency, but they can't really take their thiamine from the blood inside the cells, and as a result, that's why they tend to have intracellular thiamine deficiency. And we know thiamine is important for lots of functional cells without getting into details. Now, a few years ago, do you want me to stop or continue? Yeah. A few years ago, we collected a large number of patients with these conditions, 31 patients from 16 countries, and we looked at the impact of thiamine therapy. And as you can see, some of these patients, the majority of them have improvement in their hemoglobin A1C. The anemia resolved in all of these patients, but unfortunately, the deafness persisted, and 4 of them became completely off insulin. And these are the patients who were recognized and started very early on. Now, I would like you to remember, if you have a child of consanguineous background with diabetes, extrapancreatic feature, to consider genetic testing to rule out the genetic form of diabetes. So this girl did not have type 1 diabetes. In fact, she had what we call monogenic diabetes, and it illustrated the importance of knowing the genetic etiology or the defect in this girl. And that's why knowing the exact cause of the diabetes helps you to choose the best treatment of this girl, and in this case, thiamine. And that's this is the concept, what we call precision medicine, and I'm sure you heard about this term. Right, shall I finish with these two quickly? This is a quiz. This is a 10-year-old girl, again from Yamba, came with lots of results. You can see here in her hand, she's carrying her file from Yamba. And basically, she was short. You can see her here on the growth chart. She is below the normal. Her weight is fine. And we know from medical students or from medical school, if you got somebody who's short with normal weight, then we always think about growth hormone deficiency. But it's not always the case, by the way. So this girl was thoroughly investigated. And the only thing we found is the hemoglobin was on the low side, 7.5. Any diagnosis? Can anybody say anything? Right. Would you do celiac screening on this girl, knowing that she is normal weight? Yes? No? Yes? Yes? Okay. Would you do growth hormone stimulation because she is short with normal weight? Yes? No? Okay. So we did celiac screening, and that turned out to be positive. And in fact, this girl got celiac disease. One thing I'd like you to remember, or a few things really about celiac disease, is it's not always symptomatic. This girl only came with short stature, with normal weight. There are different mechanisms why did this happen. I listed them here, but I think we're running out of time, so we're not going to explain why. But you need to remember, if you have a short child, he or she should be screened for celiac disease regardless of their weight. Final one, this is the last one. Diagnosis, rickets. Which one, the one on the left or the right? Both? Healed. The one on the left is rickets, and the one on the right is healed rickets. Okay, this is the biochemistry. Never make a diagnosis based on X-ray alone. So what happened here? The alkaline phosphatase was high, the calcium was low. On the left side, phosphate was also low. On the right side, calcium is very high, phosphate is normal, and the alkaline phosphatase dropped down to below the normal range. Diagnosis? Yeah, the one on the right, the one on the left has got rickets. The one on the right has got a condition called hypophosphatasia. And it looks like rickets, but the difference, if you can see here, the change is confined to the epiphysis, but here they can extend down to the metaphyseal place. And this is something you really need to be aware of. Not just on the X-ray, look at the alkaline phosphatase. So this boy, they look like rickets. I mean, he's got a wide rest here. He's got some rickety rosary, and this is his X-ray, and this is his biochemistry. He came to me at the age of 14 months, and this is his biochemistry. Calcium was high, alkaline phosphatase was low, both at 6 months and 9 months, and it was overlooked because we pediatrician and physician in general, we look at higher levels of alkaline phosphatase. That's what alert us. The lab usually put an automatic alert for high alkaline phosphatase. But low alkaline phosphatase, unless you are really vigilant, you can miss it. And this is an example here. This is from our lab. You can see here the reference range for the alkaline phosphatase. I put it in the red box. Anything less than 500 is considered to be normal, where in fact, this boy would have been missed if you rely on this. Now, the other thing I would like you to remember is the alkaline phosphatase normal range is age and gender dependent. The children tend to have a higher alkaline phosphatase compared to adult, and boys tend to have slightly higher alkaline phosphatase compared to girls. Now with this, I think, as I said initially, we all make mistakes, but I think the most important thing is to learn from them and make sure not to repeat them again. Thank you very much.
ميرسي جدا دكتور، يعني صراحة محاضرة رائعة، ويعني فعلا تيبس اند تريكس. لينا بقى سؤال. دلوقتي احنا عندنا السكريننج يعني ابتدى يتحط السكريننج من ضمنها الكونجنتال ادرينال هايبربليزيا 2017 هيدروكسي بروجسترون، ان هو بيتسحب في الحضانة سكريننج. عايزه راي حضرتك وايه يعني التيبس اللي نقدر نقولها للجنرال بيدياتريشن او للنيوناتولوجيست لو احنا في الحضانه ولقينا ان التست جاي لنا بوزيتيف عالي.
Right. I mean, I think we do the same thing. We screen for lots of metabolic conditions, congenital hypothyroidism, as well as congenital adrenal hyperplasia, and they take it from cord blood, by the way. Now, if you have a high reading, unless it's really 3-digit, 100 and plus, then you have to repeat it. And you have to bear in mind that the electrolytes will not be abnormal, as you've seen in this child, during the neonatal period or during the first few days of life. So you can rely on the congenital screening or the screening, newborn screening, but it's not always correct. You have to repeat it later on when you get the child.
يعني what if the neonate is sick يعني هتفرق الكات اوف يا عبد الهادي ولا؟
I don't know. I've been doing endocrine for nearly 30 years now, and I can't recall a child who's been with CAH who was sick during the first few days of life. They do compensate these patients. They don't run. I mean, the abnormalities, you see it after the first week. It's not usually for boys. Typically, they come after 10 days of life. Girls, you can diagnose them on the spot because they tend to have ambiguous genitalia, but I think the electrolytes and the level of sickness, because these patients, they do have steroid reserve, so they produce reserve. They can protect themselves up to a point where they just decompensate. So I think in the first few days of life, I wouldn't expect babies with CAH to be that sick. That's done. Thank you very much.
بسم الله الرحمن الرحيم.